All right, so first of all, I'd like to thank the HRB for the invitation. So I think we all know the benefits to an evidence-based approach to medicine, which involves comparing competing medicines or therapies in sufficiently powered randomized controlled trials, which were one time seen as the only way you could prove causation. In contrast, in epidemiology, which is the area I work, often the goal is to establish the causal impact of lifestyle risk factors such as diet or physiology such as body mass index on disease on a population level. And often randomized trials are impossible, and instead we need to estimate causal effects using messy observational data, which is not an easy task. But still, it's crucial that we can accurately estimate these effects, primarily so that we can intervene on the correct risk factors to reduce the prevalence of certain diseases. Now, for instance, we've previously estimated that 48% of strokes would be prevented if nobody was hypertensive. So this 48% is an estimated population attributable fraction. These calculations usually assume a threshold. For instance, hypertension is defined as above 140 milligrams of mercury in systolic blood pressure. And this effectively assumes that the risk of disease may be the same in two people, one who has borderline hypertension and one who has a blood pressure of 170. And such an approximation can result in a substantial underestimate of the influence of the risk factor on disease. But perhaps more importantly, it can confuse the ordering of risk factor importance and may lead to a suboptimal policy decision. So instead of this, we've recently been defining and developing new attributable fractions that respect the underlying continuity of the exposure that's thresholded when defining a risk factor. So these new calculations result in more realistic estimates of disease burden and an improved ordering of risk factor importance. But paradoxically, the 48% will be an overestimate of the effect of intervening on hypertension in the population. So a thing about attributable fractions is they refer to removing lifetime exposure to a risk factor, and that's impossible. So for instance, take Mary, not the same Mary as before, who's age 60 and has high blood pressure. So perhaps Mary can reduce her blood pressure through a combination of diet and exercise, but in reality, she may be still at greater risk of disease than Maggie, who never had high blood pressure. So as a result of this, while attributable fractions are useful to measure the influence of a risk factor on disease on a population level, they're unfit to estimate the effect of a distributional change in the underlying exposure that might result from a health intervention, and different estimation tools and metrics are necessary to assess those effects. So as an example, suppose we can encourage a certain percentage of the retired population to engage in a brisk 30-minute daily walk. How might you estimate the causal effect of that successful intervention on the risk of stroke? Well, it's important to consider the causal pathways by which increased exercise may reduce the risk of stroke. Perhaps exercise reduces stress levels, which in turn reduces stroke risk. Perhaps exercise reduces blood pressure, and perhaps exercise has a direct effect on stroke that's not mediated through exercise or blood pressure. Unfortunately, often inadequate consideration is given to these causal pathways, which results in biased estimates of the effect of the intervention. So at the moment, I'm developing Bayesian network models, and these are graphical models that explicitly represent the causal pathways between risk factors and perhaps multiple diseases. A nice thing about these models is they have dynamic versions. That is, they can represent a joint evolution of risk factors and disease over multiple time periods. So take, for example, Mary, who through exercise and control of her diet reduced her blood pressure. These models can, data permitting, tell policymakers how much people like Mary have reduced their probability of disease. And this is the end goal of our analyses, better public health advice and better policy decisions through improved statistical estimation. Thank you very much.